So I have no conflict of interest at first. Before I started, my name is Felix Bremmer, come from Germany, and especially the city of Göttingen. And to show you where Göttingen is right in the middle of Germany. So when you are maybe have a visit to Germany, it is a beautiful old city with our famous son of the city, that's Karl Friedrich Gauss, you know him very well, I think, and that's our Munich University Medical Center. I'm just sitting here right behind this tree. So when you are visited, have a, or plan a visit to Germany, you should come to Göttingen, of course. When we're starting the seminar today, we have a new WHO classification in the year 2022, and as you can see, the last decades, the size of the books of the WHO classification is getting more and more bigger. And the intervals between the books are getting fewer. So the problem we have, or the main challenge is we have to work with more and more tumor entities in a shorter time. And that is one point that our routinely work or diagnostic process is getting more difficult in the next years, I think. Nevertheless, in the current WHO classification, we found we established a very good classification system for testis tumors. And but when you look at the several different histological diagnosis you can, or there are in tumor types in the testis, you see there are more than 50 different tumor types in the testis. So it's really hard and to diagnose every tumor entity as well as you can. And so to make it easier for you, it's important that you look at one pathological finding, and this is the germ cell neoplasia in situ. This lesion is extremely important in the diagnostic process of every tumor, and you will have to discover in the testis. And when you have a look on, I make a picture of several histological or morphological testis tissue, tumor-free testis tissues. It will show you that that's a challenge to find fast the right diagnosis, or to find the diagnosis of a germ cell neoplasia in situ. And then sometimes it will be or should be important that you have to perform immunohistochemistry. And in my opinion, the staining for OP34 is the most reliable marker to find the germ cell neoplasia in situ. So in my opinion, when you look at the several histological types of testis tumors, you have more than 50 tumor types. That is really difficult. But when you look at the tumor diagnosis which are related to a germ cell, or tumors are derived from the germ cell neoplasia in situ, it more than 90% of the tumor types. So when you look for the germ cell neoplasia in situ, it makes it more easier for you to find the right diagnosis. So to start with the seminar, we tried always to look at the tumor-free tissue and look if there may be a germ cell neoplasia in situ. So I put together some different cases, which are not really difficult in the first view, but I learned really much from these cases. So I hope we can work, or you learn also something for your routine or the diagnostic process in the next minutes. So normally, the most common tumor you will see in the testis is this one. You have a solid tumor mass in the testis, young patient. You have maybe tumor-free testis, tissue beside the tumor. And when you look in this tumor type, you see a solid tumor mass with septs, fibrous septs, which include lymphocytes or plasma cells. And when you go more in detail, you see this pleomorphic tumor cells with prominent nucleoli, and always the lymphocytes and the plasma cells beside the tumor cells. And when you look in the tumor-free testis, you will see the germ cell neoplasia in situ morphologically. And when you have doubts in the diagnosis of a germ cell neoplasia in situ, perform an immunohistochemistry with OP34 or D240, and then you are on the right way. And when you are not really sure what subtype of germ cell tumor it is, you can also perform an OP34 staining or D240 staining that will help you to find the right diagnosis. So in this case, this easier case, and many of these tumors, I think you also had seen in your career, that is not really a problem. But also this, I think, boring tumor entity from germ cell tumors can have some challenges which make the diagnosis more difficult. And one point is that these tumors are usually negative for keratin. Most of the cases are negative, but you can have some tumor types or tumors which are positive for keratins, especially in the mediastinum, or you have retroperitoneal lymph node with seminoma or lymph node metastasis. And then you should think about or remember that the seminomas do also have can also have keratin positivity. So a strong keratin positivity does not exclude the seminoma. So please recover that maybe in the case where you have this situation. So the next thing, which is very interesting in my opinion in seminomas, is that seminomas can also have cytotrophoblasts, which are positive for beta ICG, which can cause elevated beta CG serum levels in the patient. So when you have this case, you should report these cytotrophoblasts that the urologists know where the beta HCG elevated serum levels come from. Another challenge or morphology which you can see in seminomas are granulomas. Seminomas can have granulomas. About 15% of the cases can have granulomas. So this is an interesting finding, but it's in the first view maybe not really difficult to diagnose a seminoma with granulomas, but these granulomas and also the lymphatic infiltration of the tumor can make the diagnosis more difficult. And this is one case some weeks ago where I had a seminoma with many lymphocyte and plasma cells and granulomas, and it was such a strong inflammation that you did not see really good the tumor cells. So it can be that when you make an immunohistochemistry, it can be that you only see some tumor cells in these tumors. And also in the tumor-free testis, you can see in these granulomas in the testis tubuli. So this can be morphologically can be a challenge that makes problems. So when you have granulomas in the testis or in a tumor in the testis, stop don't make only orchitis with granulomas or granulomatous orchitis. Think about that seminomas can have many granulomas. So in doubtful cases, perform an immunohistochemistry with OC34, and then you will find the tumor cells. Another interesting and challenging point is that especially when the tumors are not really fixed very well with formalin, and it can be that that you see a seminoma like this with many lymphocytes and plasma cells, and sometimes it can mimic a Sertoli cell tumor, which I see one time in per year, where colleagues said that there could be a Sertoli cell tumor, but the Sertoli cell tumors are not so pleomorphic, or the tumor cells are not so pleomorphic as seminoma cells, not the highest proliferation activity. So, but from the first point of view, it can mimic a Sertoli cell tumor when it's not really fixed very well. So remember this point, and when you have this with in the next in your next case. I am starting with some challenges or cases with challenges I had the last month. I put them together and to show you. So the first case I found was a small clinical information. So I had a 54-year-old patient with a cervical lymph node swelling, and the clinicians had the indications to extirpation the lymph node, and they thought about a lymphoma. What is an old patient, and extirpation was made, and this is the slide of the lymph node, and the clinicians asked me, what type of lymphoma is it? And I said, oh, I'm not really sure if it is really a lymphoma, where you have fibrosis, you have some lymphocytes, and you have necrotic areas, and you see here the tumor cells. When you go more in detail, you see pleomorphic tumor cells, some necrotic areas, and some lymphocytes, but it can be a lymphoma, but that does not really look like a typical lymphoma. So I thought in my first diagnosis it could be a germ cell tumor, maybe a seminoma, and then I get a as you call it, shitstorm. What do you think to say it's a germ cell tumor? It's a lymphoma, and I have to recover my idea, think about my diagnosis. And but I said the tumor was positive for SAL4, it was positive for OC34 and D240, CD170, and no lymphoma markers, no PAN, no CD45, no CD20, and so on. And I said, it is a seminoma, and you have to look at the testis. Maybe you find this area of a little scar or something else. And they looked for they performed an orchiectomy because they found sonographically a small lesion. And all of the colleagues were surprised, and we looked at the testis and the morphologically, and we see completely epithelium-free testis tubuli with Leydig cell hyperplasia. And when you look at the mass or the lesion, it was a scar with some blood vessels and some lymphocytes. So I said, take together with the lymph node metastasis, I said it's a seminoma, metastasis in the lymph node, and the whole diagnosis would be regressed germ cell tumor. In the last WHO classification, it was called burned out seminoma or germ cell tumor, and now the new term is regressed germ cell tumor. So when you have this situation that maybe you find a seminoma in a lymph node, a cervical lymph node, or in a retroperitoneal biopsy, you should discuss this with your clinicians and that maybe it is a regressed germ cell tumor, and you have to look at the testis. And in this case, we perform staging analysis and find also whether the tumor was on the left testis, and you find huge retroperitoneal lymph nodes, masses or metastasis of the seminoma. The second case I find interesting, where I learned really much, was just 2 weeks ago. And it was a 22-year-old patient who presented to his doctor because he has an excellent lymph node swelling. And based on the clinical findings, he only had a lymph node swelling. Indication for lymph node extirpation was made similar to the first case. And the colleagues, it was a consulting case, said, I see a tumor mass in this lymph node, and you see a glandular differentiated tumor with necrotic areas. And when you get more in detail, you see pleomorphic tumor cells with glandular morphology, necrosis. And the colleagues said they performed immunohistochemical markers such as BLAB and OCT3/4, but it was negative. And what could it be? We are not really know what it is. And we performed SALT4 because it was an extra-testicular tumor mass, and it was strongly positive for SALT4. And so we could say it's germ cell tumor with a high percentage. It is a germ cell tumor, and this tumor has also been positive for FOXA2. And FOXA2 is a perfect marker for the diagnosis of a yolk sac tumor. And also other markers such as glipizan-3 or AFP was not as strong as FOXA2, but it was also in some tumor cells positive. And in this situation, the colleagues said the patient should be performed an orchiectomy, and they looked sonographically on the testis and found a tumor, and not really big, but so 1 to 1.5 centimeters. And they found a tumor with major epithelium. As you can see here, it's a squamous epithelium with some lymphocytes beside the major epithelium. And you also see, similar to the first case, a scar beside the major tissue and some lymphocytes and some calcifications. And but beside the tumor, not really germ cell neoplasia in situ was found, and immunohistochemically we did not found germ cell neoplasia in situ. And also we did not found similar morphology areas as in the lymph node metastasis. So in my opinion, I tried to get the connection between the metastasis and to the primary tumor, and performed in both tumors isochromosome 12p analysis, and in both tumors there was isochromosome 12p. So we found that this is a germ cell tumor. It's a type 2 germ cell tumor, a post-pubertal germ cell tumor. And we taken together the diagnosis that the testis tumor was also a regressed or burned out germ cell tumor, but without regression of the major teratoma component. So in my opinion, the germ cell, the yolk sac tumor component was also regressed, and the major teratoma areas were still vital, and in the metastasis we found the yolk sac tumor component. So a really challenging case, because we need to find the connection between two tumors, and for you it's important that the yolk sac tumor can mimic many other tumors. We will see it in one of the next cases. So when you have a suspect morphology OCT3/4 negative, it can be a yolk sac tumor. So looking for the next case, it was a consulting case, and it was a little bit tragic because it was a young patient, 29 years old, had a testis tumor. And the colleague said, what is it? I performed immunohistochemistry. The tumor was negative for PLAB, it was negative for CD117, and especially negative for OCT3/4. And he performed in the assumption that it could be a sex cord stromal tumor. He performed inhibin staining, and he thought that some tumor cells might have a slight positivity for inhibin. And he said, could it be a Sertoli cell tumor? And we look here at this tumor, see the related testis, and here we see the tumor. It looks like similar to the axilla metastasis of the patient before. And when you see in the overview the tumor cells, maybe in the first idea you can think about the Sertoli cell tumor, but when you're getting more in detail, you will see that these tumor cells are, that's not really similar to a Sertoli cell tumor, that the tumor cells are more pleomorphic. You have nucleoli, you have apoptosis, and in some areas also mitosis. But when you look in other areas, you see between the glandulas some fibrostroma, which maybe can look like a Sertoli cell tumor, but Sertoli cell tumors do not have such a pleomorphism in the tumor cells. And we found some area with some myxoid, similar to myxoid morphology. And what the colleagues did not really focus on was the tumor-free testis. And in the tumor-free testis, there were testis tubuli with atypical germ cells, with calcification, microlithiasis, and when you perform a OCT3/4 stain, you see that there is a germ cell neoplasia in situ, and that the tumors itself was negative, which is a typical finding in yolk sac tumors, because yolk sac tumors are typically OCT3, or per definition OCT3/4 negative, and but the germ cell neoplasia in situ is positive. So when you had, in my opinion, especially in morphology challenging cases, it is important to look at the tumor-free testis, and maybe you perform an immunohistochemistry and you see there's a germ cell neoplasia in situ, and now you're in the region of, or the area of type 2 germ cell tumors. The tumor was also positive for SAL4. I performed in this case, and FOXA2, which was also positive. So we could exclude the Sertoli cell tumor, and we could diagnose the yolk sac tumor. And I always say, when I make seminars and tips and such as presentations, yolk sac tumors are hummingbirds. You have so many morphological patterns of yolk sac tumors, like solid, hepatoid, or microcystic, macrocystic, papillary, endodermal sinus pattern, or sarcomatoid morphologies. And it is really challenging when you have a tumor in the testis where you think, what could it be? Think about the the fact that York sac tumors can have a huge morphological spectrum, and when you think about the York sac tumors, you will, I think you will be surprised how many times you will find this tumor entity. So when we want to learn one thing today, think about the York sac tumors, and it's a really challenging tumor subtype of the germ cell tumors. So when we go through the classification of the germ cell tumors, we in the center of the diagnostic process is the germ cell neoplasia in situ. This germ cell neoplasia in situ will help you to find or to exclude type 1 or type 3 tumors, and then when you have it, you are always in the range of type 2 germ cell tumors, and then you have to look, is it a OCT3/4 positive type 2 germ cell tumor, which would be a seminal or embryonal carcinoma, and when you have OCT3/4 negative tumors, you are in the range of choriocarcinomas and York sac tumors. And it is this we have for the germ cell tumors of the testis. We do have good immunohistochemical markers. When you have maybe doubts in your diagnosis, make an immunohistochemistry, and it works. We do have good markers. The only thing where it's difficult with the immunohistochemistry is in teratomas, because teratomas do not have one or two clear immunohistochemical findings. In teratomas, the morphology is that thing you have to do, and not really the immunohistochemistry. And when you have a teratoma or a component with where you think it's a teratoma, you can have major tissues. Mostly, or you often see, not mostly, often you can see chondroid tissues, or in the major tissues, also epithelial or epithelium with squamous differentiation, or others. And when you have immature areas of teratomas, you will see, maybe you will see embryonic neuroectomal tissue, like in this picture you can see this. So getting back again to the classification, it is important to differentiate a teratoma in the type 2 germ cell tumors, which is always or in the highest percentage is always a malignant teratoma. So you have to differentiate it from a prepubertal teratoma, which is not associated with a germ cell neoplasia in situ. This is very important to differentiate, because only teratomas in the testis with from kids are mostly benign, and when you have a postpubertal teratoma in as a type 2 germ cell tumor, it's a malignant tumor. And so you have major areas or major tissue, and you have immature tissue. But major does not mean that the tumor is benign. It also only means that the tumor is have major areas, but it's not benign. It's also a malignant tumor. So, looking at this classification of germ cell tumor in the testis, we will see the next challenge I want to show you, and that is an area or a region of somatic transformation or somatic type malignancy. It was well known that this tumor entity or this subtype of germ cell tumors develop from teratomas. More common or actual findings and papers show that there's also a possibility that York sac tumors too also can perform somatic transformation, but that's more a scientific thing. I think that the challenge is that when you have a germ cell tumor and maybe after chemotherapy, you will see tumors which have a rhabdomyosarcomatoid morphology, like in rhabdomyosarcomas. Desmin positivity or myogenin positivity. That's the most common somatic type malignancy. That's as from the sarcoma group, can have rhabdomyosarcomas or nephroblastomas is also a possibility. But you also can have carcinomas not otherwise specified. You can also have angiosarcomas, which it's a more common finding in the mediastinum. And you also have sarcomas, which you cannot really classify, or you call it NOS. But in the last year, it's getting more public that that the somatic type malignancy exists, and in the new WHO classification, there was a focus on this tumor entity. But the term rhabdomyosarcoma or angiosarcoma, it is a little bit not perfect, I would say, and that's why it's very important that it's Thomas Albright, Andy Acosta, and Dan Burney wrote this proposal where they discuss a potential new term for these tumor entities, and that's the current classification said you have a somatic type rhabdomyosarcoma or angiosarcoma and so on. But these tumors do not have the same changes or molecular findings as their counterparts in the body. So the proposed classification is more a sarcoma-like tumor of germ cell origin, rhabdomyoblastic phenotype or vascular phenotype. That's a really good idea, and I think that will be a very important point in the coming WHO classification. So with this case or this challenge, I will close the germ cell tumor part. And I now have some other challenging cases, such as this case. I'm sure everybody of you saw a tumor like this. It's a well circumscribed tumor mass, not really big. And when you go more in detail, you see eosinophilic oncocytic tumor with edematous dissociation of the tumor cells. Not really necrotic areas or no necrotic areas. When you go more in detail, you may see some lipofuscin pigments, not really pleomorphism of the tumor cells, and you see the oncocytic morphology. This tumor is morphology is clear. It's in the first idea, it's a sex cord stromal tumor. And when you have doubts, you can perform immunohistochemistry such as SF1 or calretinine and inhibin also. And these tumors are, this tumor is classically positive for these three markers. The proliferation activity is usually not really high, about 1%. And if you have in 1/3 of the cases, you may see these crystals, which called Reinke crystals. And these Reinke crystals, you can see are negative in the inhibin staining. That's really interesting. Maybe I'm not sure if this Reinke crystals, you may look more in detail in the inhibin staining, and they are interestingly positive in the calretinine staining. So when you have this, the next tumor, maybe perform immunohistochemistry. Look if you find, or you also find these changes, it would be it's really interesting. And so taken together, this tumor is not really a challenge. Because I'm really sure you have sought such cases, and that's you make a good diagnosis. The really challenging point in these tumors are which of these tumors are benign or which have an aggressive biological behavior. And for this question, Maurizio Colleccia from Milan performed a very good analysis in a paper where he established the Leidig cell tumor scale score, and he found some points in which are important in the idea or for the biological behavior of these tumors. And this includes the mitosis, the size of the tumor, necrosis, infiltration of the tumor cells, vascular invasion. And as you can see, when you have some points, you can make a risk class, low risk class or a high risk class. And you see in many points of how big the tumor, the size, and bigger tumors, you have two points. And when you see mitosis, you are in a high risk class. So when you are not really sure what is the biological behavior of these tumors, look for the Leidig scale. The Leidig cell tumor scale score will help you in your classification, especially regarding the biological behavior. And the next challenge we have to discover in the next years is two new entities who look similar to the Leidig cell tumors, but has another biological behavior and clinical outcome. And these are the FH deficient Leidig cell tumor and the inflammatory and nested testicular sex cord stromal or sex cord tumor. And why is it also from Maurizio and Dan Burney a correspondence where they think that the FH deficient testicular sex cord stromal tumor, why is it so important to look for these FH deficient tumors? It's similar like the FH deficient renal cell carcinomas, which are almost included in the new WHO classification. These tumors do have more pleomorphic tumor cells, can have sex cord Sertoli cell components, and these tumors are FH deficient. And these tumors have a more aggressive behavior than the normal Leidig cell tumor. So I think when you have a Leidig cell tumor which has not the cytologic blunt morphology, think about this tumor entity, perform an FH staining. It's relatively easy to perform because it's, I think in the oncocytic or eosinophilic tumors, there are many changes in the next years, as we saw in the WHO classification of the renal cell tumors. And another important new entity would be the inflammatory and nested testicular sex cord stromal tumor. It looks similar, also maybe you can remember as a Leidig cell tumor, as a more maybe more rhabdoid phenotype when I use this term. And you have inflammation between these more pleomorphic tumor cells. And why it is important to know that there are such tumors is that this tumor entity in the paper from Thomas Albright, that these tumors are immunohistochemically positive for inhibin. And that's the challenge that you have to think about this tumor entity, that they are positive for inhibin, but they do have an EWSR1 gene fusion with ATF1. And these tumors are highly aggressive and have a bad outcome and aggressive biological behavior. So these two tumor entities you will see in the next years, maybe more often than in the last years. So with the look on the time, I have one really challenging case, which is not a typical finding, but I learned so much with this case because I had to work up all differential diagnosis. And I will show you this case. It was a 32-year-old patient. He had a tumor in the epididymis. And the colleague favored the diagnosis of a papillary or maybe a cyst adenoma of the epidermis. And that was the first diagnosis. And 3 months later, the patient had a recurrence of the tumor in the epidermis. And so the recurrence also was operated and extracted. And this is the tumor. It's extract from the epidermis. We see a cystic tumor, not really, not really something special. But when you look more in detail, you see cystic areas. And so here with epithelium, we get more in detail. You see mostly cytological, mostly bland cells. Maybe when you go more in detail with a slight kinocilian kinocells on the top of the epithelium. But there was one thing was not really sure. There was also one little area with some spindle cells beside the epithelial cells. So the first idea was a cyst adenoma of the epidermis, and the colleague said had not really typical immunohistochemical findings. So the first thing I did was to make immunohistochemistry at the first tumor, and I looked in the WHO classification. And when you look, when you have a tumor of the epidermis, and you look there, you look for the cyst adenoma, you see more clear cell tumor, and these tumors are more like a clear cell carcinoma or something else from the renal, from the kidney. And the first thing I did was Ki67 staining, and it was not really high, but it was not really low. I looked for mesothelial markers with WT1. It was clearly negative in the tumor cells, and PAX8 was also negative. And that's not really a typical finding when you have tumors in the testis, epididymis, or on the rete testis, and they're usually positive for PAX8. And we looked for the keratin staining, and we see that the epithelial component was clearly positive, but the spindle cells were negative. So I go back to the WHO classification, and there is a really good table for these rare entities. Where are they? On the left side, you have the tumor entity, where it is located, how old the patients are, what is the morphology, and then what is the immunohistochemical finding in these tumors. And when you look for the papillary cyst adenoma, you look here for cuboid epithelial with clear cytoplasm. It was not really the case in this tumor, and they are positive for PAX8. And then you should say, okay, maybe my first idea was a cyst adenoma of the epididymis, but it doesn't have the typical findings, not the morphology and not the immunohistochemistry. So I looked for the second, for the recurrence tumor, and there was one area which was more, there were more tumor, and in this area you see a more clear biphasic phenotype of the tumor with epithelial component and the stromal component. And we performed all the mesothelial markers because mesotheliomas can have a biphasic appearance also, but all of the mesothelial markers were negative. So, and the second thing I thought is biphasic tumors, and which diagnosis with the biphasic tumor type. And I thought about sarcomas with a biphasic tumor type, and thought about the biphasic synovial sarcoma, and performed TLE1, and it was clearly nuclear positive, but we do know that TLE1 is not the perfect immunohistochemical marker to diagnose these tumor entities. So I performed the fish staining, and it was a TLE1 translocation with SSX1 we found in the area. Sorry, I didn't get. But we found the translocation partner was SSX1, and it was a biphasic synovial sarcoma. So in my opinion, it is important to think about, be cautioned, as in this case, with the diagnosis of an adenoma of the epididymis without clear cell morphology and PAX8 negativity. Or in other words, one should refrain from making the diagnosis if the morphological findings and the immunohistochemical findings do not match. So I learned really much in this case, and I hope you too. I think with the look on the time, we have 45 minutes, Sarah. I think we make a cut here. I want to thank you for your attention, and with the final greetings from Göttingen, with that's our Gänseliesel. That's a fountain in the center of our in the center of Göttingen, and this is so when you finish your doctoral thesis as a student, you are allowed to, or you have to bring the Gänseliesel flowers, and you are allowed to kiss her once, one time in your life, and so we believe that our Gänseliesel is maybe the most kissed girl in the world. So a little greetings from Göttingen. So thank you for your attention.
Thank you, Felix. That's a great story, and obviously a very lovely town. We do have one question currently in the Q&A. If anyone has other questions they'd like to ask, we'll use that function. So please feel free to enter them there. Felix, would you prefer to read? Are you able to see it?
Yes, I mean, the question is, as the same factors may, like cryptorchidism, may increase both germ cell neoplasia in situ and invasive and sex-cord stromal tumor. Coexistence of both is to be expected, and I think we should not overestimate the significance of germ cell neoplasia. I mean, that's a long question. I think that is correct. The cryptorchidism is a risk factor for germ cell neoplasia in situ, and also for the for type 2 germ cell tumors, and not really for the sex-cord stromal tumors. That is in my idea, it's not really a risk factor. Is to be expected. Yes, that's. I mean, cryptorchidism is not a really pathological finding, more a clinical finding, and but you're right, and I think we should not overestimate the significance. Yes.
I mean, I do think, particularly for the case that you showed, where they were going down the wrong path regarding whether or not it was a germ cell tumor or it was regressed, where germ cell neoplasia in situ absolutely is the thing that will allow you to make a diagnosis. So I do find it very helpful. It's not always clear on the H&E. You showed excellent examples of that, but I find it to be a very useful indicator of what sort of tumor you need to be working up. If it's an unusual look to a germ cell tumor and there's GCNIS in the background, that's incredibly helpful. So you're at least working in the same category.
I mean, I think that the germ cell neoplasia in situ is it helps you to find the right diagnosis, especially in these cases. I will not really overestimate they did not see the malignant tumor. So I think, in my opinion, it's my personal, it makes it easier. I mean, the reflex you see a tumor, could it be? And in my experiences, it makes sense to look at the tumor free testis. Do we have a germ cell neoplasia in situ? Yes or no? If you have it, then you are in a type 2 germ cell tumor. If you have it not, it's not. It's getting really difficult. That's correct. And there's another if the case has any sex cord stromal tumor, and indeed we find germ cell here, can we call it as a mixed germ? Yes, that's a really good question. Maybe the tumor or both tumor types. It's really rare. I did not see many of these cases, but when you see a germ cell neoplasia in situ, you should also always look for an invasive germ cell tumor. That should we do, and in these cases we also should perform immunohistochemical analysis, because when you have the germ cell neoplasia in situ, you have a higher percentage of invasive germ cell tumor. So, but I mean, your idea was if there is only a germ cell neoplasia in situ and not an invasive tumor, I will not call it mixed germ cell tumor with sex cord, but I would discuss in these cases with the clinicians and said, there is a germ cell neoplasia in situ, you should make some analysis to look, and also on the other testes there are germ cell neoplasia in situ and sonographically, and but I will, when I do not have the invasive component, I will not call it mixed germ cell tumor with sex cord. I would not do it. And Christoph, also, I never met germ cell neoplasia with sex cord stromal tumor as a criterion. I mean, there are cases when you where you can find germ cell neoplasia in situ that are really some cases only case reports, but that's not a common finding. Absolutely not. That's not a common finding.
Yeah, I was curious while we're talking about GCNIS. I've not encountered it, but if you find it in, say, a cryptorchid specimen where, you know, there's a little bit of GCNIS but no tumor, what is your discussion with the clinicians in terms of the other testis?
I think that's I would lie when I would say I have the ideal answer to this question. I think it depends a little bit of how old the patient is. Is it a child, or is it an older man who has maybe no familiar planning or plans? It's difficult, but I think it would be important to. It's more a clinician question, but I would discuss it with the clinician and said you have to look more often at the other testes to find to miss invasive tumor. I think that
right
would be the best.
So treat it as a risk lesion for development of germ cell tumor on the other side. Yeah, I think that's, again, I haven't seen it, but I think that's kind of the approach.
I mean, there are rare conditions, I think, but in this individual discussion with the clinicians in these cases, I think would be better.
Okay, well, that was about perfect timing. So thank you everybody for joining. Thank you, Felix, for some really wonderful cases, particularly that synovial sarcoma. I think reminds us why we go through general training and learn about all these different things, because they don't always happen in the expected location. So wonderful to share.
I mean, these cases are, and I think I will never see a case like this anytime. But I learned to work with the differential diagnosis in this region. I think that's it. We take the the book and look inside the book. And I think the things there in the WHO classification will help you really good to find the right diagnosis, or to exclude the assumpted diagnosis or the first diagnosis. Okay.
Okay. Thank you. Have a wonderful evening.
Thank you, Sarah.
Bye.
Bye.